Sixth step. So we now have a person who has a dementia syndrome. We need to work out what the cause of the syndrome is. The tragedy is to miss a reversible cause. One of my teachers was Professor Kylo. He published a study in 1961 called pseudo-dementia. And he had 20% of, I think it was 100 or 200 patients who came to his clinic had a reversible course for dementia. Half of the 20%, so 10%, were psychiatric disorders, mainly depression, and half were things like B12 deficiency, thyroid deficiency, normal pressure hydrocephalus, tumours, neurosyphilis. We run a memory clinic at Prince of Wales Hospital. I run it. And we hardly ever see a reversible cause these days because most people are having these tests done as a routine. And it's important to do the test. It doesn't cost very much. And for neuroimaging, the minimum is a CT scan without contrast. It's the cheapest and it's the easiest for the patient. And for most patients, particularly the old, it's enough. And if you want more detail about investigations, we've published all the recommended lists of investigations plus the synthesis that we think are adequate. So what we do is we do a full blood count and either an ESR or C-reactive protein. We do a clinical chemistry. Some panels of chemistry don't include a calcium. It's important to include that. Thyroid function, B12 and folate, and a CT scan of the brain without contrast. In our specialty clinic, we do MRI scans. If indicated, an ECG, chest X-ray, EEG, we found a low yield from EEG. We stopped doing those routinely. We do microurine routinely, not because it's the cause of dementia, because we just find a high rate of urinary infection in older people, particularly women. We do fasting glucose, lipids, and I should have had homocysteine on this list as well, and I'll come to that. We used to do routine syphilis, but we found such a low yield, and what happened is we picked up people who had previous infections, and it caused such ructions in the marriage when this unknown past peccadillo was revealed, or HIV. But so if there is some history to worry about it, then we go ahead with that. MRI, SPECT, and PET scans, and these are mainly investigations that a specialist will order. Advances in biomarkers. The new diagnostic criteria are moving to biomarker-derived diagnoses. Again, these are more specialist clinics at this stage, but they're going to come. Lumbar punctures, analysis of the CSF, and showing a reduction in the amyloid beta protein. Because what happens in Alzheimer's is you build up plaques and tangles in the brain. The plaques are the deposition of an amyloid beta protein, or A beta protein. It takes 25 or 30 years. A molecule a second for 30 years, and you have a plaque. And it's now thought that these plaques are in fact the body's defense against the A beta protein, which when it clumps together as oligomers are toxic. And so the body shoves these into the plaques to try and get them out of the way. And so the levels of A beta protein, the CSF, go down. Intuitively you think they go up, but they're going down because they're in the plaques. The other thing that's happening is we're getting the nerve cells internally twisted because the tau protein that maintains them in a nice shape, maintains the cytoskeleton, gets phosphorylated. And if we measure levels of tau protein in the CSF, they go up, particularly phospho-tau. And so using an algorithm of phospho-tau plus A beta protein, we can demonstrate with 90% accuracy in people with dementia that it's Alzheimer's. You can do serial MRI scans. And here we see, this is the hippocampus. And it's healthy. And this is the fissure between the hippocampus. And we see that this is gradually getting larger and larger, and hippocampus is getting smaller. And this is the entorhinal cortex, and that's shrinking. And so serial MRI scans, or even one MRI scan showing a lot of atrophy in the hippocampus, is something that influences us to make that diagnosis. We don't have in Australia SPECT scans with dopamine labelling, which can be useful for showing Lewy body dementia and Parkinson's. And PET scans, I'll show you the next slide. So here is a normal person, and here is a person with Alzheimer's. And the hotter the colours, the more plaque. So here's the patient with Alzheimer's and lots of red, a lot of plaque. Here are 3 patients with MCI, mild cognitive impairment. This one looks just normal. This one looks just like Alzheimer's. Within a year, the iceberg will have come out more, and this person will be diagnosed with Alzheimer's disease. This one is intermediate, and we'll watch them. So there may be some time before they have Alzheimer's disease clinically diagnosed.